it's happy. Presumably I'm the last speaker, and I'm so happy to see so many colleagues remaining. What I'm going to talk about is fatal CSF leak. Essentially, this is a matter of ambulance doctors. But nowadays, there's many consultations come to us as a spine surgeon. The content that I will talk today is published already. The typical example, 40-year-old, unmarried, healthy business person. One reason to delay to reach a correct diagnosis. Headache during standing and sitting since last 1 month. It goes gradually worse. His headache improves while lying in the bed. Headache worsened with time and become intolerable for daily social activity in the last few days. Initial 3 weeks, patient is okay, still he can work, but afterwards it gets worse and he remains alone at home and nobody will help. Some terrible thing will occur. And the patient visited for the first time to doctor. CT scan demonstrated thin bilateral subarachnoid hematoma or effusion. Of course, the initial contacted doctor didn't reach the correct diagnosis. So initial diagnosis of the first contacted doctor are mild subarachnoid hemorrhage, headache with such a high density area at corner. Angiography was performed, second reason to be delayed, but negative finding. It is only a coincidence that the same patient had CT scan 2 years ago due to head trauma. This is a CT scan 2 years before, and you can difference and see how it differs. Ventricle is so small. And finally, the doctor reached to the same correct diagnosis. It is 5th day from his admission. It is about 35 days, 7 weeks after symptom onset. MRI was taken in our institution. On this surgical image, is this normal or not pathological? Normal? Pathological? Pathological, yeah. Later on, I will show. On admission, the patient was neurologically free except for his headache. Blood patches planned on the same day on admission. However, patient was postponed after patient request because he had a wedding ceremony of closest friend in 5 days, and we are allowed to let him go. This is a second failure. The patient consciousness deteriorated on the 5th day after wedding ceremony. On the MRI, second subdural hematoma. What will do? Burr irrigation? What we did is simultaneous blood patch and burr irrigation for chronic subdural hematoma. This is tiny tips. Normally, we let a young resident to do this blood patch. And nobody can, we employ targeted blood patch, and nobody can be sure how safe it is. Therefore, we combined ORAM, and also we inject blood with containing CT contrast media in order to see how far the blood reach. Normally, the story was so. This is days after symptom onset. It will get gradually worse, and normally, initial visit to medical attention is 10 to 20 days after symptom onset. And we have such 11 deteriorated cases so far, and average of deterioration is about 1 month, 7 weeks, 7 weeks, no, 5 weeks, 5 weeks. Therapeutic window is therefore only 2 weeks. Then severe crisis is waiting. That's the point of no return. You know why we are so aggressive in this type of disease? This is another case, 68-year male, headache while standing since at once. The first contact doctor diagnosed properly in this case. This is a T1 image with contrast media. And yeah, it is not so terrible, but it is also pathologic. You agree? The patient were treated conservatively at the initial institution and deteriorated and became comatose on 4 weeks after admission and was referred to us further 3 days later. This is an MRI image of admission to our hospital. Clearly, this is central herniation, perfect central herniation. If we want to compare these, and those who don't know this type of disease will start with burr irrigation, but it makes things more worse because air coming in and brain sinks further. This is when we look back this sequential MRI of this patient, blood patch was done at this point, and 65 days later. This looks like normal. This is normal MRI. When I look back to the first MRI, it is already pathognomonic. Without knowing this finding, probably we lose chance. But this, after point of return, the patient is so terrible due to central herniation. 3 days after central herniation, nothing can do. We could do nothing to help him. This is also resemble case, sinking down, and this patient was initially treated by blood patch but incomplete. Therefore, patient recovered a little bit but no more. And again, we did it again. Occasionally, in case we fail a blood patch, we see some calcified area, calcified disc. And if you approach to there operatively, you may see a tiny hole on the ventral side of dura mater. Therefore, in this meaning, idiopathic spinal cord herniation and this type of disease is relatives. If spinal cord goes out, then stops CSDH leak, but then spinal cord herniation can occur. But if spinal cord remains in this place, then CSDH occurs. Do not do burr irrigation first. If necessary, always in combination with blood patch or direct peer. Our contemporary therapeutic radar is so consciousness disorder. If patient has only headache, then conservative therapy. But if conservative therapy, patient don't respond 10 days long conservative therapy, or if CT scan sagittal reconstruction image shows a brain sinking, sign of brain sinking, then we switch on to blood patch with irrigation. If consciousness disorder exists, of course we do. And if blood patch failed, then we go direct repair. So the take-home message, although most CSF leak heals spontaneously by conservative treatment only, several cases deteriorate and become fatal. Therapeutic time window in such cases are limited. Even if patients are in good condition and was decided to be treated conservatively, one need care and prepare for immediate treatment. CT sagittal reconstruction is much easier than MRI to take, and today, CT sagittal reconstruction image is good enough for this kind of diagnosis. And most important is that without knowing this knowledge, disaster may occur for both doctors and patients. Thank you.
Thank you, Dr. Taniguchi. Any questions? It's a very rare condition.
No more rare.
Not rare?
No more rare.
I wouldn't say that is rare, because as a matter of fact, and I don't come from a big country, and every year we have like 2 patients with idiopathic intracranial hypotension, and as a matter of fact, we have a protocol with the anesthesiologists and neurologists about this, and what we always do is that we don't look for the defect. We do lumbar epidural blood patch that works in 50% of the patients. So if you put the patient and you do an epidural blood patch like post-epidural anesthesia, is the same thing. So if you put the patient, if you do epidural blood patch and tilt the patient, put the patient in Trendelenburg position, even if it's a cervical fistula, most of the patient, it heals. And our protocol is we do that, and about 50% of the patients improve, that resolve. If it doesn't, we repeat the lumbar blood patch, and with the second blood patch, the total rate of improvement is 80% in our series. And only if it doesn't improve after the second patch, we do an MRI and try to see where the defect is. And after that, if the MRI within sequences, like myelographic sequences, show a point of fistula, we do a third epidural blood patch near that zone, and we never had to operate the patient.
Yeah.
So this is
I agree.
my experience.
In the same time window, we have 3 times more successfully treated cases. We don't do lumbar blood patch, only target blood patch. But 25% of all cases were treated only conservatively, letting his patient lying down. And even though, and we are not emergency hospital, even though we have 11 in last 4 or 5 years, yeah, there exists, and it is overlooked everywhere in emergency ambulance service. Now, many conflicts between patient and neurosurgeon occurring in Japan because they did burr irrigation first, and patient become worse.
Beautiful case, congratulations. The reason that your presentation is here in this spine section is that the cause, the pathophysiological mechanism underlying subdural, chronic, subacute, or acute blood collection is spinal. Because the reason can be both osteophyte at the cervical spine and also herniated disc and thoracic and lumbar spine with a well-documented by MRI fistula in the periradicular facts. You can follow with MRI T2 weighted sequences the CSF circulation from the intraspinal compartment up to the periradicular compartment. I completely agree with Dr. Pereira. The more close to the fistula, to the shunt you are with blood patch, the best follow-up you can expect. Unfortunately, it is not always possible. I remember a couple of cases with a point of fistula